Hi, everybody. I think I know most people in here very well, but I'm Lisa Miller. I'm the program director for the Preventive Medicine residency. And welcome back from Thanksgiving. Everybody looks well fed. What? You're still being well fed? Good. I think maybe we'll have a few trickle in as we get started here, but I don't want to shortchange Jessica, so we'll get started. So I just want to introduce Jessica. Jessica Elf is a assistant professor of epidemiology in the Department of Environmental and Radiological Health Sciences at the College of Veterinary Medicine and Biomedical Sciences at Colorado State University. So we want to thank her for traveling down from CSU. That can be a challenging drive at times. And I, for one, am really interested to hear this talk. I love the fact that she's talking about integrating these different areas of science and medicine. And I think we all know that so many of our problems are really complex and they require this integrative approach. So I'm excited to hear her talk about HIV, tuberculosis, tobacco, and air pollution.
Thank you. Thanks for having me. In addition to my appointment at CSU, I have an affiliated appointment with the Colorado School of Public Health, and I'm happy to be here today to talk to you about some of the work that I'm doing related to these 4 areas of research and how they interact with each other. So I have no disclosures to declare. So there's a well-established overlap between HIV and TB co-epidemics. They're very strongly linked, and the World Health Organization calls for synergy between these 2 programs. We also know that combined air pollution and tobacco cause 13 million deaths every year worldwide. And they actually have a fair amount in common if you think about it. They're both socially determined risk factors, where people in lower socioeconomic categories often are at higher risk for exposure. They have similar pathways of exposure, similar health risks, and mechanistic pathways as well. So the work that I'm doing is thinking about the overlap of air pollution and tobacco with HIV-TB co-epidemics. So today we'll talk a little bit about HIV-TB epidemiology. I'll talk a little bit about air pollution and tuberculosis. Then we'll bring in tobacco and think about the overlap between HIV, TB, and tobacco. Talk about some of the prevalence work that I'm doing in Washington, D.C. and in South Africa, as well as some strategies for intervention. And then finally, we'll talk about these 4 things together and some of the work that I'm doing in South Africa and just some ideas about what could happen here in the U.S. So first on the epi of HIV and TB. Oops, there we go. So antiretroviral therapy has dramatically improved in the past decade or so, and this greatly improves the prognosis of people living with HIV. The WHO currently recommends anyone with an HIV diagnosis to be put on antiretroviral therapy, regardless of their CD4 count. And this, in combination with strengthening HIV programs, has dramatically reduced the number of AIDS-related deaths that we see. So in this figure, you see the blue line, the number of AIDS-related deaths decreasing as the green bars, ART coverage increasing. And we are starting to think about management of HIV less as like an acute death sentence and more like a chronic disease where people are engaged in care for a much longer period of time. But we're not out of the woods yet. Worldwide, there are still 38 million people living with HIV and 1.7 million new infections every year. We have 770,000 AIDS-related deaths every year as well. People with HIV have a compromised immune system and are a vulnerable population and susceptible to opportunistic infection and disease, TB being one of the main ones that we think about. TB is the leading cause of death among people with HIV, and it causes 1 in 3 AIDS-related deaths worldwide. It's also important to note that 50% of the TB cases among people with HIV are not diagnosed and treated. We can also see that geographically there's a very strong overlap between HIV and TB epidemics. with the map on the left being the number of people with HIV, and then the map on the right, TB incidence rate, and the more intense colors are clearly overlapping in a number of countries. So what is TB? I think perhaps in this room right now, most people are familiar with it, but for those of you who are not, TB is an infectious disease caused by Mycobacterium tuberculosis. Well, pulmonary TB of the lungs, where people are coughing, is most common and is what we most often think about with TB disease. It actually can affect any organ of the body. Transmission happens through the inhalation of airborne droplets. So if I have TB and I cough or talk or sing, those droplets are aerosolized and carry bacteria to people who may inhale them. Once people inhale an airborne droplet, they may be infected with TB and get what's called latent infection or a subclinical infection, where they don't have any symptoms. And from there, a handful of people will transition to active disease, which is what we think about when we think about TB, where people are coughing or they have some clinical symptoms. And it's important to note that people are only infectious when they do have this active pulmonary TB, not latent infection. And risk factors that increase people's transition from latent infection to active disease include those that compromise immunity. And worldwide, it is estimated that there are a quarter of the world's population are infected with TB. It's quite a bit. So we don't often hear as much about TB as we do about HIV, but it's important to note that we are in a TB emergency, that we have a large global burden with 10 million cases each year and nearly 1.5 million deaths. TB is actually the leading cause of death from an infectious agent worldwide, surpassing HIV. The figure on the left shows the incident number of TB cases, and the figure on the right, the incidence rate. And clearly we have a little ways to go before we meet our milestones. It's also important to note that while we consider HIV a really important risk factor for TB, 91% of the new cases and 83% of TB deaths worldwide are in people who are HIV uninfected. TB is a classic disease of poverty, and it affects those most often who are in low socioeconomic conditions. Social determinants that increase risk from transitioning from infection to disease include undernutrition, tobacco smoking, which we'll talk a little bit about later, crowding, alcohol use, and we hypothesize air pollution, but we're not really 100% sure. So we'll talk a little bit now about air pollution and tuberculosis. We think air pollution, both household air pollution and ambient air pollution, is associated with increased risk for tuberculosis, as it's associated with other respiratory disease, including lung cancer, COPD, respiratory infection, and asthma. Additionally, there's biological plausibility. Exposure to air pollution induces airway inflammation, decreases alveolar macrophage function, and precipitates changes to lung morphology, which may make people more susceptible to TB. However, the scientific evidence that we currently have about this relationship is inconclusive. So this is a systematic review from 2014, including a handful of studies on household air pollution, primarily measured as biomass fuel use and an outcome of active TB. And the moral of this story is that the evidence is inconclusive. This is due to perhaps a number of things. A lot of the studies included in this systematic review aren't very strong. There are limitations in statistical methods and the way our exposure is measured. So people are typically only asking about biomass fuel use, which may lead to some misclassification error. And they're primarily not capturing other sources of household air pollution exposure as well. Additionally, there was a large study that was published this year coming out of Nepal, a large case control study. I believe it had approximately 500 cases and 1,000 controls. And it actually found a strong protective effect from biomass fuel use with an outcome of active TB disease among women, with an odds ratio of 0.21 that was statistically significant. There have been some studies looking at ambient air pollution and TB, but again, the story is the same. There's some mixed results. Nothing is really strong or pointing to, yes, air pollution, PM2.5, other components of air pollution are associated with TB. So some of the work that I've been doing is to continue to explore the relationship between air pollution and TB. And the bulk of this work has happened in India. This figure is several years old, but I think does a really great job of showing the burden of TB that we see in India. India has 2.7 million incident cases every year and has the largest number of TB, incident TB of any country in the world by a long shot. There are 450,000 annual deaths from TB. And here in India, the TB epidemic is not driven by HIV. Only 3% of TB cases in India are HIV co-infected. Here, TB is likely driven by social determinants, including air pollution, tobacco, undernutrition. And in India, 64% of people use biomass fuels. So if air pollution is indeed associated with TB, this could have big impacts for a country like India. So I collaborated with Sassoon General Hospital and BJ Medical College in Pune, India, to conduct a case control study to look at this association. So Pune is a large urban center in Maharashtra, about a 2.5 to 3 hour drive outside of Mumbai, with a TB incidence of 185 per 100,000. Sassoon General Hospital is a large tertiary government hospital primarily serving low-income communities in Pune and the surrounding areas. As I mentioned, we conducted a matched case control study. This was among children less than 5 years of age and adult women with biologically confirmed TB, and we recruited matched controls based on neighborhood, age, and sex. All participants in this study, both case and control households, were visited as part of the study. When we visited the homes, we administered a questionnaire to capture socio-demographic information as well as self-reported measures of air pollution. We also conducted an environmental assessment of household PM2.5 concentration over a period of 24 hours. So we placed a PDR direct reading monitor with a downstream filter for gravimetric measurement, one by one meters away from the primary cook stove for a period of 24 hours. And this hopefully does a better job of capturing household concentration of PM2.5 and is a more objective measure than just what people are reporting happening. So I just have a couple of pictures of our field staff, Sunitha and Vaishali, in the field, doing questionnaires and placing field equipment. So here we have Vaishali placing some air monitors in the home. And here they're primarily LPG and kerosene stoves. But in this community, even in the urban areas, we did find a number of people using wood for heat for cooking as well. So in total, we recruited 192 participants in 96 pairs. These participants were from low socioeconomic conditions. About 28% had less than primary education. 40% were unskilled manual workers or were unemployed. There was about 13 to 15% food insecurity in this population, and 42% had no separate cooking area in their homes. These were primarily in kind of your shantytown areas, many people living in a small area. We did find that people are reporting primarily using LPG as their fuel for cooking. We do find, however, that there is fuel stacking, or people using multiple types of fuel. 13% of our participants are using kerosene, and nearly a quarter are using wood as a secondary fuel in the home. As such, we created a variable as to whether or not people were using kerosene or wood, and in total, 17% of our homes were using kerosene, and 26% were using wood. I would like to note that in this population, no one reported any sort of heating, so we didn't include any sort of variable for what fuel people were using for heating. In a conditional logistic regression with TB as our outcome of interest, we found that for reported exposure to household air pollution, wood cooking fuel had an effect size of about 2. This was not statistically significant, but in line with some of the other stronger studies out there, outside of that Nepal study that I talked about what the effect size might be. We also found a strong, positive, significant relationship between kerosene use in the home and a reported kerosene use in the home and TB. I'd like to highlight that we used the data from this study to assess the contribution of reported sources of air pollution to our objective measure of household PM2.5 concentration to inform some of the models that we did for the exposure-disease relationship. So we built a linear regression model with PM2.5 as our outcome of interest and the reported sources of household air pollution as our exposures of interest to try to understand what was contributing to PM2.5. In this analysis, we found that kerosene is not significantly contributing to our PM2.5 mass load, but that wood was. It's likely that kerosene isn't contributing because the PM2.5 products of combustion for kerosene are submicron particles and therefore aren't substantially contributing to our PM2.5 mass load when other things are producing the majority of this. I would also like to note that the median PM2.5 concentration in homes was 167 micrograms per meter cubed, and the WHO 24-hour recommended limit for the limit is 25 micrograms per meter cubed, and the interim target for high burden countries is 75. So all of our homes, even though 88% are reporting primarily using LPG, have a very high PM2.5 burden in their home. So back to the exposure-disease relationship. We conducted regression to try to assess whether or not PM2.5 and kerosene in the same model were associated with TB. And in the just analysis, we did not find any association between 24-hour PM2.5 and our outcome of TB. We also did not find any association between PM2.5, the number of hours that a household had above 75 micrograms per meter cubed using our real-time measurement and TB. However, in all of these models, we did find a strong positive association between kerosene and our outcome of TB, even after adjusting for PM2.5. So we expect kerosene might increase the odds of TB for a number of reasons. I mentioned submicron particles that kerosene combustion produces. It may deposit more deeply in the lungs, bypassing some of our clearance mechanisms. And some of the components of kerosene may be perhaps more toxic than wood use, for example. So as I mentioned, we didn't find any association between PM2.5 and our outcome of TB, but we have these filters that we wanted to continue to use to explore perhaps if there are some components of the PM2.5 mass that may be associated with TB. As such, we assessed the PM2.5 mass for heavy metal concentration, the metals that you can see here. And I'd like to note that across all households, there was a moderate range of metal concentrations. We didn't see anything that stood out or anything that was abnormal than other published literature. We only saw a couple of differences by wood, no differences by kerosene, but we did look at the difference in metal concentration between households that were sampled in the winter months versus households that were sampled in the non-winter months. We were not able to look at winter or season as a variable in our main exposure disease relationship because, as I mentioned, these are matched homes, and the visits happened in the same season, usually within a couple of weeks of each other. So this variability we were not able to tease out. But we did look at, in total, how the metals may differ, considering the sources of pollution might be different in the winter versus in the summer. For example, there's a lot more trash burning in the winter for heating outside of the home. And in the winter months, we see differences in a number of metals here: arsenic, cadmium, copper, iron, magnesium, nickel, lead, antimony, tin, and zinc. So we are continuing to explore this data. This is just a preliminary analysis of what we found. We also looked at the concentration of metals in this PM2.5 in a univariate analysis with TB as our outcome of interest. And I'd like to note this is a smaller sample size in total, an N of about 134, given the filters that we had that we could successfully collect and those that were successfully analyzed. We didn't really see a difference between many of the metals in our outcome of TB. We then stratified by adults versus children. Perhaps adults or children are more exposed to one or the other, or are more susceptible to some metals than others. And we see that nickel, the effect size for nickel slightly increases for women. And we also find that for children, the effect size for arsenic and molybdenum do increase. There are a lot of limitations with this data that I'm presenting to you now, but this is just some exploratory analysis that we're doing to try to get a better grasp about why we may or may not be seeing some sort of effect size for reported measures or PM2.5. So some of my next steps to continue to explore the relationship between air pollution and TB is to utilize C-TRIUMPH, which is a large cohort study of TB in India. So TB index cases are recruited, and them and their household numbers are followed for a period of 24 months and are tested regularly for TB. There's a lot of information collected as part of this cohort study, including household air pollution in a subset. So we'll continue to explore that relationship. And we'll also try to tease out what the population attributable fraction may be for air pollution, as well as some other socially determinate risk factors for TB. Your standard population attributable fraction is to be used traditionally when for a single risk factor. And as you can imagine, in many of these situations, people have multiple overlying risk factors: undernutrition, exposure to household air pollution, tobacco use, et cetera. So we'll first calculate or estimate the odds of TB, or the risk of TB in this population, and then we'll explore multiple types of population attributable fractions that account for overlying risk, multiple risk factors. So the big picture is that prevention is important. About 40% of estimated new cases go undiagnosed or are not reported. And the WHO NTB strategy includes multiple areas where air pollution applies. A guiding principle is protection and promotion of human rights, ethics, and equity. And a key component is social protection, poverty alleviation, and action on other determinants of TB. Air pollution is likely important for this. Additionally, the NTB strategy targets by 2035 are quite aggressive, and attention to the role of air pollution in TB is likely important in helping us achieve these goals. I think it's important for us to know how air pollution is associated with TB. This includes both household air pollution and ambient air pollution, the exposure response curve, if there is an association, perhaps what sources are important if we're thinking about interventions, and what reductions in exposure are actually meaningful. If air pollution is indeed associated with TB, we need to know what intervention strategies are effective, how cost-effective these strategies may be, and how this might impact the HIV-TB co-epidemic. So I've talked about how TB is a concern for people with HIV, and we know that tobacco use increases the risk for TB. So now I'd like to talk a little bit about tobacco use in the context of HIV. Thinking about people with HIV as a disparate population for tobacco use. And as we move forward, I'd like to ask you to keep in mind the similarities between who might be exposed and the health risks between tobacco and air pollution. So we've made great advances in tobacco control, but we still have quite a high smoking prevalence. And it's estimated that 1 billion people in the 21st century will die of tobacco-related causes, and that's primarily in low and middle income countries. Data from high resource settings are showing us that people who have HIV have a much higher prevalence of tobacco use than the general population, ranging anywhere from 40 to 70%, depending upon the study. But as we saw from the graphs, the maps before, our burden of HIV is actually in low and middle income countries. So we need a little bit more data from high resource settings. So just to talk a little bit about the prevalence of HIV a bit more. In Washington, D.C., for example, there are over 13,000 people living with HIV, and the prevalence is 2%, which reaches epidemic levels. And there are certain populations, not surprising, that are at much higher risk for HIV than others. Black males, for example, have a prevalence of over 4%. So I'm collaborating with researchers at George Washington University who are running the DC cohort to look at tobacco use in a population of people with HIV in the DC area. The DC cohort is a large prospective observational study using medical record abstraction of over 8,000 people in the region, in the DC area that have HIV. And they have collected information about smoking at baseline, and baseline only at this point. So in our analysis, we found that 42% of people in this cohort are self-reporting current smoking, and 19% are self-reporting former smoking. And that's in comparison to the estimated 15% adult prevalence among the general population in the US, so quite a bit higher. Even among people with HIV, we are also finding that there are certain subpopulations that are at higher risk for tobacco use and for smoking. For example, people who are non-Hispanic Blacks, people who identify as transgender, people with HIV who are in lower socioeconomic status categories, and not surprisingly, people who have other substance issues are a particularly higher risk for smoking than those other categories. We're also starting to explore the concept of comorbidities in people with HIV and people who use tobacco. So comorbid conditions among people with HIV make treatment of HIV and their comorbid conditions more complex, as there's multiple things to address. And in general, people who have comorbidities and use tobacco have a harder time quitting. They have less access to resources, higher risk to continue smoking, and other competing health concerns that may make tobacco cessation more difficult. So we're looking at people with HIV in this DC cohort who have comorbidities, and are finding, not surprisingly, that tobacco use is also a concern. We're finding that while overall 42% of people in this cohort are smoking, people with cardiovascular, pulmonary, and mental health comorbidities have a prevalence of above 50%. And as people have increasing number of comorbidities, not surprising, the prevalence of tobacco use increases as well. So tobacco use among people with HIV threatens advances that have been made in HIV care. People living with HIV who are on antiretroviral therapy, as compared to their seronegative peers, are at higher risk for pulmonary comorbidities, including tuberculosis, malignancies, and cardiovascular disease. People who smoke are also at risk for these things. The increased risk from people who have HIV is thought to be due to low-grade inflammation, some of the antiretroviral therapy drugs that they're taking, as well as other aspects related to their infection status. And while smoking doubles the risk of TB, it's not just TB that we're worried about. There was a study in JAMA Internal Medicine in 2017 that modeled lung cancer mortality among people living with HIV in the United States, and found that the cumulative lung cancer mortality by age 80 among heavy smokers was 30%. Encouragingly, that dropped to below 10% for former heavy smokers, but ART adherent smokers who are on ART adherent people with HIV who are smokers are 6 to 13 times more likely to die of lung cancer than they are of an AIDS-related illness. So tobacco use is highly prevalent in this community and is emerging as a major cause of morbidity and mortality. But as I mentioned, the majority of our burden of HIV is happening in low and middle income countries, not in our high resource settings. For example, South Africa. South Africa has the largest burden of HIV in the world, with 7.7 million people living with HIV. They have 240,000 new HIV infections annually and an adult prevalence of 20%. This is often higher in certain subpopulations who are higher risk for HIV. Like other low and middle income countries, tobacco use in this context is extremely important but understudied. So in order to start addressing this, my colleagues and I conducted a smoking prevalence study among people living with HIV in Matlosana, South Africa. This was in collaboration with the Perinatal HIV Research Unit at WITS. And this was, like I said, conducted in Matlosana in the Northwest Province. The antenatal HIV prevalence here is 30%, and they have a TB incidence of over 700 per 100,000. So it's quite high, very high burden setting. We randomly selected adults from 3 HIV clinics to participate in this prevalence survey. And we administered questionnaires to assess socio-demographic information, as well as self-reported smoking status. And we also biochemically verified smoking status through an exhaled breath carbon monoxide measurement and urine cotinine. Cotinine is a metabolite of nicotine. We recruited just over 1,200 participants. About 60% were female, and the median age range was 40, which mirrors the epidemic in this area. 10% reported were currently on TB medication, so currently had TB. 80% both reported trying to quit in the past month and in the past year, and said that they were interested in quitting in the next year. So overall, we found a smoking prevalence of 28%, and this was 52% among men and 13% among women. So half of our men with HIV are currently smoking. This is much higher than that in the general population. We find that 32% of men and 7% of women smoke in South Africa. When we looked at the correlates, we stratified by sex because there was such a large difference. And surprisingly, we didn't find any difference in prevalence based on socioeconomic status. And not surprisingly, we found that people who reported marijuana use and people who reported alcohol misuse had a higher prevalence of smoking as well. This was also the case among women. And when we looked at this analysis in regression, we found that these held as well. I'd also like to point out that while we were not looking at smokeless tobacco use, there was one question that we asked about snuff use, which is a fine powdered smokeless tobacco product that people will inhale through their nose. Unfortunately, we only asked one question, whether or not you use snuff. And in this primary prevalence survey, 50% of the women reported, yes, they did use snuff. So we did an analysis of this prevalence survey to try to explore that a little bit more, even though we only had one variable. So we included only the 606 non-smoking women. Most people who smoked did not use snuff and vice versa. So we excluded smokers and we excluded men, since women were the people who were primarily reporting using it. And we found about 50% of women using snuff, biochemically verified. These women were mainly older and in lower socioeconomic categories. So unlike smoking, we did find a divide by age and SES for snuff use. And interestingly, people who reported ever or currently having TB had a much higher prevalence of smoking, of snuff use than those who did not. As I mentioned, we had urine cotinine tests that were completed, cotinine being that metabolite of nicotine. And using urine cotinine as our exposure of interest and TB as our outcome of interest, we found a 20% increase in risk of ever having TB among people who had a positive urine cotinine test, and more than a 5 times greater odds of currently having TB among people who had a positive urine cotinine test. Fortunately, we're relatively limited in our interpretation. It's a cross-sectional study, and this study was not designed to assess the association between snuff and TB, and we only have the one question, whether or not people use snuff. So currently, there is an MPH student at CSU who is working to explore this a little bit more, trying to understand how people are using snuff, their attitudes and behaviors about it, and whether or not we can get people to quit. We're about halfway through data collection right now, but anecdotally, there are, of course, a variety of different patterns of snuff use. There's actually quite a large interest in quitting. I think a lot of people are interested in our study because they think that it is an intervention study for cessation. And we're also finding a large burden of depressive symptoms and mental health issues, which is not surprising in this community, but something that should be taken into consideration as we think about developing interventions. So speaking of interventions, we know that tobacco use is bad for the general population, and we should have some interventions, whether or not it's related to TB or these other outcomes in our HIV population as well. So in South Africa, we conducted an individually randomized controlled trial with just over 560 people. looking at intensive cessation counseling alone versus intensive cessation counseling plus nicotine replacement therapy in the form of patches and gum. Our primary outcome was biologically confirmed quit at 6 months using both exhaled breath carbon monoxide and urine cotinine. So at our 6-month outcome, the intent to treat analysis showed no difference between the two arms. So nicotine replacement therapy addition did not help. In addition, with this intensive behavioral counseling, only 15% of people were able to quit. We had baseline 2 weeks, 4 weeks, 6 weeks, a number of counseling sessions where people would come in and receive support. And it just didn't seem to work. We also really didn't see any difference at 12 months. And it's interesting that in the counseling arm, we had a higher proportion quit than in the counseling plus NRT arm. So needless to say, this was a little bit disappointing, but we are continuing to explore some ways to enhance this intervention. We had a student who went and did a qualitative analysis of people who were involved in this study to try to understand some of the challenges of quitting, and not surprisingly, stress was a major reason for relapse. But I think what's important to note are the reasons for stress in this community. There are economic reasons, social and interpersonal reasons, and individual reasons. People were stressed because they didn't have an income, they didn't have a job. There's a very high unemployment rate in this community. They felt that they didn't have support due to their HIV infection status or trying to quit from family and friends. There's a lot of individual stress due to personal difficulties, people in their lives who are dying or passing away, or violence given the community that they're living in. So we're trying to use some of this information to better develop an intervention strategy. In addition, we collected urine samples at baseline, which we are analyzing for the nicotine metabolite ratio. Nicotine metabolite ratio is a measure of how quickly people metabolize nicotine and is associated with difficulty in quitting and whether or not a nicotine patch is effective, and also the number of cigarettes people are using to smoke. So this will hopefully contribute to future studies that we do in this population to better inform a more successful cessation strategy. In addition, we have conducted a pilot randomized control trial, very small, about 25 people, in DC to test a new tailored behavioral intervention paired with a text messaging program. So this tailored intervention uses the minority stress model as a framework, thinking that in these populations, we have multiple intersecting stigmas that may make it difficult for people to quit. This includes HIV status, socioeconomic status, race, sexual minority status, whether or not people have been incarcerated, drug use, and that all of these may make it more particularly difficult for people to quit. So we're targeting identity evaluation, thinking about coping skills to both reduce stress and then help to cope with that stress when they come across it. We're currently analyzing this data, and hopefully in combination with the results that we found from the DC cohort will inform a more robust intervention strategy. So the big picture takeaways are that people with HIV are a highly vulnerable population at high risk for both tobacco-related diseases, including TB. They have a very high prevalence of tobacco use, and high quality evidence on smoking cessation interventions in this vulnerable, often difficult to reach population is lacking. But we do have these existing HIV and TB programs. These are strong existing programs where people are receiving long-term and regular care, and it may be ideal to integrate tobacco use, tobacco cessation programs into these existing HIV and TB programs. But we need to know what intervention strategies are effective. And we need to know what the health benefits are. In order for HIV and TB programs to put resources into smoking cessation, we need to let them know that this is actually helping achieve their own goals as well. And once we have these, we need to do some implementation science to understand how we can integrate these existing cessation strategies into the healthcare system. And importantly, how cost-effective this might be. So finally, I'd like to talk a little bit about the air pollution work that I'm doing in these populations as well. I've only just started, so I don't have a lot to share with you, but I'm excited about this moving forward. So I first started to think about air pollution in HIV populations in this Matlosana district in South Africa. There was an ongoing TB case finding study where they were going to homes of indexed TB cases and testing everyone in their household for TB and HIV. And I tagged along a small sub-study for this, which was a questionnaire for reported exposure to household air pollution, as well as placing passive air nicotine monitors in the home. This was about 53 homes in this community. And the HIV prevalence was about 40%, if I'm remembering correctly. Was about 40%, and about 23% of homes reported using paraffin or kerosene and wood for cooking. So these are homes where there's an active case of TB, and 23% are using these fuels for cooking. 15% are using them for heating in the home, for a combined 30% of homes using either kerosene or wood for cooking or heating. Additionally, 40% of these homes reported an active daily smoker, and 70% of these homes had detectable levels of air nicotine. So some pretty important exposures in a community with a high burden of HIV and TB. Additionally, that prevalence survey where we talked about smoking and snuff use, we also asked some questions about fuel use in the home for cooking and heating. And among men, about 17% reported using any sort of wood or kerosene for cooking or heating in the home. And we found that this prevalence was a little bit higher among smokers. Not surprisingly, we find that people use tobacco if they're in lower socioeconomic conditions, and people are less likely to be able to afford LPG or electricity if they're in these conditions as well. And we're also finding this case for women in this survey as well. 17%, 16% are reporting kerosene and wood use, and this is slightly higher among women who are smoking and women who are using snuff. So there's perhaps a creep of dual burden here. And I haven't started to look at air pollution exposure in the US yet, but I think that there's indication that's perhaps important. The map on the left is the number of HIV cases in Washington, DC throughout the wards, the different wards. And the map on the right is median income by census tract. And there's clearly an overlap between where the HIV burden is and where our low socioeconomic status burden is. And while we haven't yet measured air pollution exposure in these communities, we know that people who are in lower socioeconomic status conditions are more highly exposed to environmental pollutants, both in the home and outside of the home. So I think there's some indication that perhaps this is something that might be important. And while TB may not be a big problem in the US, other things like lung cancer, other malignancies, pulmonary comorbidities, and cardiovascular disease are. So HIV overall, HIV and TB are leading causes of morbidity and mortality worldwide. They are highly vulnerable and stigmatized populations, which makes intervening much more difficult, but also gives us that ethical imperative to do so. There's a large overlap between HIV, TB, tobacco, and air pollution, but relatively little research and very few interventions considering the magnitude of the health impact. And there's clearly a need for collaboration across interest groups. We need to know what the epidemiology of air pollution exposure in the HIV population is. And we also need to understand the health impacts of this exposure, as well as exposure reduction. This will help us inform how tobacco and air pollution interventions may benefit HIV and TB program goals. And I think it's also interesting to ask whether or not HIV and TB focused household level interventions may confer additional benefit to other household members. So if we have an HIV or a TB index case and we go and we provide an intervention to reduce household or tobacco use exposure among that person, for example, how does that benefit other members of their household as well? So I'd just like to return to this figure and leave you with a thought that there's plenty of need in this HIV-TB population to think about air pollution and tobacco control. Or if you're an air pollution and tobacco person, there's plenty of need in the HIV-TB community for the work that you do. There's a lot of need and opportunity for collaboration and innovation across these four fields. So I'd like to thank my collaborators and my funding sources and I am happy to take any questions.